You're listening to In Network, Nordic's podcast series where we explore healthcare and technology with experts from around the globe.
Hello, and welcome to the In Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. I recently sat down with Dr. Mark Townsend, Executive in Residence at Secours Mercy Health. We talk about Dr. Townsend's path from internal medicine and cardiology to his current role as a health system administrator. We also discuss his work with emerging healthcare startups, balancing cybersecurity and customization within the electronic health record, and what it means to fail forward. Let's plug in. Mark, welcome to the podcast. How are you today?
Doing great. Thanks for having me.
It is a pleasure to have you, a well-known, well-established physician leader, to talk about some of the pitfalls and learnings with respect to design that you've had.
Yeah, mostly pitfalls.
Mostly pitfall. Well, that's how we learn, though, right?
That's right.
That's how we learn. So, how did you get into doing some of this work? You're an internist by training and practice, I believe. Is that true?
Yes, internal medicine, pediatrics trained, and then went on to cardiology, so adult congenital and pediatric cardiology. So I'm recovering from all of that, actually. So
fair enough. So I didn't realize that you did med peds and then you did cardiology fellowships in both peds and adult, or focusing more on one than the other?
So dating myself, I'm grandfathered in through internal medicine for adult congenital. So I did have to do, there was training guidelines that helped me through that. So I did qualify for ABIM boards in adult congenital cardiology when they finally came along, and it was a great experience. I got to help write the boards and then take them. So that was good.
That is always, I think that's a tip that our listeners should really be focused on. If you help write the boards, your chances of successfully completing the boards have gone up significantly.
Absolutely.
That's great. It's funny, I was a primary care pediatrician. I don't practice now, but I did for a while. And now when I deal with pediatric subspecialists like gastroenterologists or endocrinologists, they tell me, well, no, listen, what I need from my technology or other things to help me practice, they're very different than what the adults need, because I'm a pediatric endocrinologist or a pediatric gastroenterologist. And I always poo-poo them and say, well, it's really the same, really, isn't it? What an adult gastroenterologist does. But cardiology is actually very, very different. You take most adult cardiologists and ask them to look at a baby, and they get very, very diaphoretic and anxious appearing. So hats off to you to be able to do both of those things.
Well, and as I said, I'm recovering from all of that. And so I left clinical medicine behind to take a full administrative role 3 years ago. So here we have it. So
how did you get started? You've done some fun things that we're going to talk about that are not traditional from either a leadership perspective or from a practice perspective. One thing that I would just like to kind of understand is, how did you get to where you are? Where did you become interested in doing some of these things, working with startups and venture capital firms? How did that all happen?
Well, I became interested in working in the technology space by virtue of the fact that I needed technology, right? So as a congenital cardiologist, when no one knew what that was, I needed, for example, echo reading software. And there was a couple of prototypes out there. I happened to know a couple of guys who were pretty good at hacking, if you will. And next thing you know, we found ourselves content. And this can't go on the podcast, but necessity is the mother of invention. But building tools for the job that we needed to perform clinically was how I had my start. So, whether or not it was reading an echocardiogram, whether or not it was an electronic health record, I essentially had to build my own. So that's how I had my start.
Well, that sounds all kosher. Nothing secret.
Mostly kosher. Yeah, exactly. And the guys I partnered with went on to be CMIOs. I'll leave them nameless and blameless.
All right, that's fair. If you just tell me after the show, we'll make sure to put that secretly in the show notes.
Yeah, there you go.
And for a small fee, I'll make it more clear for people so that they can actually find out who you're talking about. So necessity was the mother of invention, and that's kind of how you got forced into it. Obviously, though, once you were there, you in some way you enjoyed yourself. You were working with, and I assume still are occasionally working with startups. Is that true?
Yes, absolutely. So, the design journey that I was on was create a tool that I need to do my job that I can't afford and that doesn't exist, right? And then that leads to, well, if I could do it for that use case, could I not apply, the same concept to an additional use case? And then the creative juices start to flow. Next thing you find yourself in over your head. And so I got involved in mobile health, and conceptually helped design a couple mobile apps that led to then some additional content development and mobilizing Million Hearts that led to additional development. And then at some point you start to realize that it's a lot of work doing it on the front end, and it's more fun to criticize other people as they're doing the work. And so there's a local incubator called Lighthouse Labs. I'm based in Richmond, Virginia. So shout out to Lighthouse Labs. And so I work with them to help distribute venture capital, to help select the healthcare cohort that is funded. That then turns into helping startups access health systems. And it gives me the advantage of being able to constructively critique the work as it is being developed. So yeah, neat space to be in. It's a creative outlet, right?
Yeah, well, that's that's very helpful, and a big differentiator between you and me is you're giving constructive criticism. I generally do destructive criticism, as folks that work with me know. Well, let's talk about Mobilizing Million Hearts. You had talked about that as a project that you worked on. What was that? How did that come about, and how did it turn out?
Yeah, so as a practicing cardiologist, trying to get your patients to buy in to improving their healthcare outcomes is the heavy lift, right? So that's healthcare. And so if you use a how might we statement, how might we help my patient achieve better health outcomes? That conceptually leads to patient education. And so we as cardiologists, when we're predicting the risk of a 10-year cardiovascular event, a heart attack or a stroke, and this is relevant for adult congenital, right? You're born with a heart problem, and now you're acquiring heart disease by virtue of the fact that you're an American. So, and we've got the oh so healthy lifestyle. Trying to engage those patients in minimizing their risk was the heavy lift. And so I found myself trying to gamify their cardiovascular risk for them to say, for example, you've got a 50% chance of having a heart attack or a stroke within the next 10 years using, that's a cardiovascular risk prediction tool. And then you pick one variable and say, but if you stop smoking, I guarantee you, your risk will decrease. Right. And so then the patient's like, well, by how much? And so that led to the concept of, okay, well, let's gamify this thing. Right. And so taking that show on the road ended up then allowing us to engage the American College of Cardiology, that went on to gamify the mobile health app, which became the teaching tool, by the way, of Mobilizing Million Hearts, the nationwide initiative to curtail heart disease. That then led to the concept of, well, we could do that as a Smart on Fire app, because it's pretty darn clunky in the middle of a patient care episode to pull out your phone and to start plugging in data points and trying to convince the patient, hang on with me, hang in there. We're going to have, a really cool outcome here for you. And I won't be able to print this and you'll have no record of this. So taking that concept, we developed a Smart on Fire app, and that turned into an ONC LEAP grant, Office of the National Coordinator LEAP grant, 2018 to 2020, which, by the way, was designed to demonstrate that we could kind of kick open the door of development in the third-party open API space to develop content for electronic health records without begging for permission. So that's what we did.
So how did that work? So now you're with a patient, you've got the electronic health record open because it's omnipresent, and you tell them that, hey, you've got a 50% chance of having a stroke in the next 10 years. But if you do some things, we can decrease that. And so right from your screen, you're able to kind of say, well, if you stop smoking, it's going to go down to this percent. But if you continue smoking, but if you lower your cholesterol, it's going to go down by this percent. But if you do both of those, is that the idea?
Exactly right, and the whole point was to embed that content within the electronic health record, so it looks and feel like the EHR, right? And so you also don't have to go and pull in the data points, the age, and the medications and whether or not they're on an antihypertensive, et cetera. So you can pull in discrete data points which fuel the application. And then you make a fire call, and then next thing you know, you've got real live data to work with. And then you can use sliders to gamify risk. So you engage your patient and say, well, so if you only took that blood pressure medication that I've been asking you to take for years, this is what it would do to your cardiovascular risk. And then next thing you know, you can visually display that in the electronic health record. You can print that and then send the patient home with it.
And by visually display, are you saying, here's 100 little icons of people, and you're going to go from this many people who are going to have a stroke to that many? Is that the kind of thing you're talking about?
Yeah, I like that, and maybe that should be the next iteration of it. It's more of a red, yellow, green construct with sliders and more of a bar graph presentation. And so your risk goes from red to green. If you make an intervention. So that's how we displayed it.
Awesome. Well, that was some free suggestions that I just gave you. I've seen others do similar type risk, explanations for patients, and that was the way it was kind of expressed. And what I thought was quite effective again is like showing 100 little people or 10 little people, and showing 3 of them as being red, which is those are the ones that are going to be affected negatively. And I've seen a physician go, which one are you? Pointing
Right.
at here's the good one, here's the bad one. Which one do you want to be in? And boy, look, if you do that, take that blood pressure medicine, there's a lot more of the good guys and fewer of the bad guys, and that seemed to be much more effective than kind of just numbers, which are a little bit more kind of difficult to make into real life, a percentage.
Yeah.
So when you were working with this, was this at MedStar? Was this at the at that time with the Center for Human Factors in Healthcare?
Yeah. So it's been said a prophet has no honor in their own country. I'm no prophet, and I have no honor in my own country. So that made it perfectly tenable that this wasn't going to work in my former healthcare institution, and I needed a partner. So I went to Ken Mendel, who's the father of Smart on Fire. And I was in grad school at the time, and he gave me a lecture. So I chased him down after the lecture and said, hey, so this is what I want to do. And he's like, oh, that'd be a great grant. You ought to apply for a grant. So a classmate of mine named Terry Fairbanks started a Human Factors Institute at MedStar. I'm based in Virginia. I was reconnected with Terry's institute, and the MedStar Center for Human Factors in Healthcare helped us partner. So Kristen Miller was really the one that did the heavy lifting with Mobilizing Million Hearts, and so we were able to use the Human Factors Institute to really help with the design of the application. So finding extreme users and putting them to work to punch holes in your concept is where we started.
Were there other kind of learnings that you might have stumbled into yourself, but that they were able to identify, quickly and say, okay, this is completely wrong? Or have you even thought about this perspective? You had mentioned kind of extreme users, the folks that are going to be on the periphery of the use cases. Were there other things?
Yeah, so once you get into content development, we all fall in love with the solution and not the problem, right? And so design thinking and challenges us to fall in love with the problem, not the solution. So, it's one thing for me to use my experience and say, okay, this is how it works in my clinic, and this is how we should do it, right? Then you get that in front of expert users, you get that in front of novice users, and what we were able to do using human factors was set users down in front of a screen, an electronic health record, and have them start engaging with our content. And one of the cool things that MedStar does, they use a technology that essentially tracks the user's visual cues with the user interface with the screen. So you can see where they're looking and then where they're engaging. And so you put content in an electronic health record where we think it's intuitive. Well, and guess what? It's not necessarily intuitive. And then, through this process, you start to refine, okay, so if I'm in the middle of a patient interaction and I need to access content, where am I going to put it And that's how we embedded it within electronic health record. That's how then we started to engage users and how did they interacted with that technology. And using those rapid cycles of continuous improvement, those short, quick cycles. All right, let's tweak this, try again, right, and keep the user pool fresh. That's how the design aspect really worked, and that's what that's what MedStar does very well.
Yeah, well, so it sounds like there's some serious technology there with the eye tracking. And were you shocked at the fact that there were people who did the same kinds of jobs as you? There are other cardiologists or internists, and who were not ready to interact with the technology that you created. I know I have been. I'm like, of course, this is the most obvious way of doing it, and I've been wrong. I mean, it's only been once, Mark, but it did happen to me. And
yeah. No, great minds think alike, right? So you assume that everyone's going to be great like you, and they're going to think just like you. But who knew? Some people don't get the memo. Like I got the white shirt memo today, and you didn't even have to tell me because we're great minds. But other people get the memo, and but they get it from someone else. Apparently, they don't get it from me.
Wow. Yeah. Well, I think we both agree that we are some of the smartest people in the room, and
for sure.
It's just everyone else that disagrees with that.
Poor souls.
I know. I feel sorry for all those people. Let's talk about some of the work that's ongoing. So you've worked with, and you had just mentioned that you're in the enviable position of giving constructive criticism to startups and folks that are looking to create either apps or other technology. How does that? How do you interact with them? How do you make constructive feedback and not the kind of destructive feedback that I give? What are some examples of things that you've seen people do that made sense to them as they're developing their apps or creating their technology that you're like, yeah, it's not going to work for most of us? Or
yeah, it's interesting. So I think the first call out is that maybe 5% of the technology that I review at some point has some significant compliance related concern. In other words, something that they're trying to do is a little bit illegal. And if you're a young developer and you're not in healthcare, you wouldn't know that. For example, enhancing documentation, using automation to improve your reimbursement in a capitated environment. Why not, right? I mean, if you can get a computer to be smarter than a human being. So I think first things first, trying to keep people out of orange jumpsuits is a start. But moving past that, having been there, done that, and falling in love with my creation, as opposed to really being in love with the problem, not the solution. I think as you extract yourself emotionally and you're interacting with startups, you commonly see that. You see people just so infatuated and so down in the weeds, so far down the rabbit hole with their own technology that there's not much oxygen down in the rabbit hole anymore. They're a little hypoxic, and they need to zoom out, get out of the rabbit hole, take a big breath of fresh air and say, hang on a second. So if you can gently mentor them, and example of that is a startup a couple of cohorts ago, so this couple cycles ago, had developed this great tool, but it was a freestanding user interface. It was, it was mobile health. It was a mobile app, and you just have another sign into another portal, and you're going to have another user interface and another screen out there, right? And why not? Because it's easier to design it that way. And then challenging these people. Well, you know what? It's going to be really hard to get traction from someone who's actually living the life of a physician or a clinician. It's going to be really hard to get traction because they're not going to log into your interface. They're not going to have another floating window in the midst of busy patient interaction. So you've got to embed that in the electronic health record. And here's how you can do that, right? Introduction to HL7, Smart on Fire, you can do that. And so that's where I'm able to intervene and in some cases and help out. It's gratifying then to see them come full circle, and that happened recently, where a startup I'd worked with had actually listened to the advice, which was kind of gratifying.
Shocking, really.
And they should have known better. But no, in this case, they came back and they had actually done it. It was so gratifying because they now have a tool that is fully integrated into an electronic health record that actually is very cool, very useful. And we're trying to bring that full circle and get that plugged back into our health system.
I'm genuinely shocked that is the most common example that you came up with, because it's exactly my experience. And we were talking about, again, your constructive ways and my destructive ways. I have told many developers that that's great what you just proposed. Are you curing cancer? Because if you are curing cancer, I am willing to go and log into that system and to have a floating screen and to do all those other things that are good for you but bad for me. But if you're not curing cancer, and almost no one is,
Right.
then I'm not going to do it. And you hit that kind of 80% mark where, this is where I live, and it's 80% of the way there, and it's good enough. And your new technology is offering me a boost up to 20%, of 20% up to 100. It's amazing, but that 20% differential is not enough. And so hence, to really get traction, it needs to be it needs to be connected, or at least appear to be in the tool where I'm spending all day. I'm not going to be flipping, even to ask someone to who's living in the electronic health record to email can be a big deal. And because that's not where they live. Have you found any other kind of trends? Are there colors? Are there sizes of fonts? Are there particular affordances in software that you've seen where people are like, no, this is great, and then you have to point out not everyone's 24 years old?
Well, the older I get, the font size, is more helpful, right? So it's it's hard to read something that is in small print anymore. But no, that aside, another fun application is wearables. There's a lot of interest in wearables, and you see in the design cohorts some pretty cool creative ideas come through. And then to be able to redirect and shape that, particularly how you take a wearable and then you ingest the data that you've curated from that, right? And that's where it can be a little bit disheartening back to, again, the electronic health record. It is, again, such a rate limiting step to be able to say, okay, well, I've created all this fantastic data. Now you're a smart doc. You figure out what to do with it, right? And you can get halfway there, right? You've created this fantastic new technology that's going to be really helpful in a movement disorder, for example. But we have no idea what to do with it. And now with that data that we've created, can we turn it into cognitive assistance? Can we turn it into something that makes the life of a clinician better, rather than one more annoying pop-up that obstructs my workflow in the midst of a clinical scenario? Can we turn it into cognitive assistance that is somehow embedded into a workflow that I, as a human being, have to suffer through, or I live through every day that I'm clinically active, right?
As you may know, I am the inventor of the pop-up, and I am offended. I'm offended by your
pop-up, yes,
by your bad attitude towards my invention of the pop-up. And I've encouraged software developers around the world to pop things more to pop up more things, Mark. So you need to tone down your pop-up attitude and get with the program.
Equal opportunity offense.
But seriously, your point is well taken. Boy, it's much better to prevent me if I'm entering a medication order or interacting somehow, with the technology. It's much better to guide me into the right direction than to yell at me after I make a mistake, right?
Amen.
And those are some of the things that I think, we who study design, at least even superficially, kind of get and humans appreciate, although they don't know why. This technology seems to be easier to use than that, and they couldn't tell you why. And it's because this one kind of guided you so it's unlikely you're going to make a mistake, and this one just let you make the mistake and then yelled at you after you made the mistake. And it would have been nice to have some advice, some gentle inline advice to kind of point me in a direction.
Cognitive assistance.
Absolutely.
Yeah.
So you've kind of given up most of your practicing career, and now you're focused on leadership. I'm assuming that governance of IT programs and other kind of technologies come across your way. How much fun is it telling people that they can have what they want or they can't have what they want or how they get what they want.
Yeah, God help us all, right? That's synonymous with governance. Yeah, there's this whole little thing about, how we're going to pay for our good idea. And, that factors into governance. And then the other little problem is, how we create vulnerabilities with our technology. And so, there's a sinister world out there, and there are people that want to do us harm, even in healthcare, right? That's the thing that kind of stifles innovation. Having been there on the front end of that, where you come up with a technology and you say, all I got to do is just plug this in, and we're going to be great. We're going to save lives, stamp out disease. It's going to be amazing. And then someone tells you, well, you've just created significant vulnerabilities in our system. No. Well, even if I did, no one's going to take advantage of those vulnerabilities. Well, apparently some people out there are. So, in this governance construct, you do have to sometimes be the naysayer. I still find myself on the other side of the argument more often than not. And more recently, trying to integrate a technology into our health system that's an AI-driven algorithm, just like every other algorithm these days, right? And that does super cool things in terms of mining data and then turning that into actionable, clinical interventions. That was supposed to be like a 2-month project. It turned into a 9-month compliance-centric project just to get it through governance, right? So I was very patient. The older I've gotten a little bit more patient, still working on that. I'm impatient with my progress and trying to become more patient. But with that whole project, I then was able to use that as an example of how we need to blow up our whole governance construct and redesign it. So in an environment where the time to market is how you protect intellectual property, that, you can't delay, you can't wait 9 months to get something approved. So that's the constant paradigm, and that we're all living in. It's it's a bit of a innovation paradox. Time is money, and how do we capitalize on technology if we're stuck in that time warp, which is compliance and governance?
So where do we put that line, that safety line? In terms of cybersecurity. I used to joke with some of the chief information security officers and lawyer type people when I was on the provider side to say, hey, I hear what you're saying about security. What we're going to do is we're just going to have one terminal, and we're going to put it in the middle of the hospital on the 5th floor of 10 floors. And we'll have 2 guards outside it, and then we'll be 100% secure, but we won't be able to treat patients. And so there's got to be some kind of give and take. Have you, what is the secret? If you could just tell us what the secret is, Mark, that would be awesome.
Yeah. No, I got all the secrets. Secrets aside, one thing that I am advocating for currently is the creation of an innovation sandbox. And give me an epic environment where I can sit down. It's a non-prod environment where I can sit down and with a team of developers, and we can just have fun, right? Epic does that, by the way, so I hear. But taking that one step further and then saying, all right, so if we do develop a technology using a sandbox internally or using Epic's tool, sure, let's then create the vehicle for us to actually get into the production environment in a secure construct. And let's have all of our compliance team in the room with us when we do it. But then let's actually create this innovation space, this incubator or this little igloo, borrowing from Google terminology. How can we do that internally as a system? So that's turned into a conversation of, okay, well, we're going to have to pick a specific location. And so, I'm based in the Richmond market. So of course it's going to be Richmond, right? If we get this right. And then if we can do that, can we pick a specific hospital and a specific physical space that is clinically active and turn it into our innovation hub? So that's where we're going with it, is let's create a sandbox. Let's create an environment where we can actually get our hands dirty, roll up our sleeves, and not hurt anybody and not hurt anything in the process, and not jeopardize, the security of our entire health system by virtue of the fact that we want to be innovative. So that's where we're going with it. I don't know if that's the right answer. Ask me in a few months. And if the compliance people get a hold of this concept, ask me in a couple of years.
Yeah. And I'll also, if I see any pictures of you wearing orange, I will. I will
Come rescue me.
I'll have well, I'm not going to rescue you, no, but I'll have
send in your people.
Yeah, no, you're stuck there at that point. But I just want to know that's where you stand with me. I will not be breaking you out of jail. Hopefully, though, you're not going to be in there. Well, let's pivot a little bit from that kind of trying to be innovative. As you may know, I worked for 3, almost 4 years in Silicon Valley area for a hospital system out there. And I certainly encountered a lot of startups that were saying some of the things that you just mentioned, which is, well, come on, it's unlikely that there'll be a problem, or come on, it's pretty close. And one of the things I heard from the Valley, as the cool people call it, is that concept of, well, let's just try this. And if we're going to fail, we'll try and fail fast and fail cheaply. Now, is this something, I understand, like you've taken this concept of kind of failing fast and talk about failing forward.
Yeah.
And I'm not sure exactly what that means. How do you fail forward?
Sure. Yeah. One of my favorite expressions: fail fast, fail forward, fail frequently. But too many F's there. But the notion is, let's not be afraid to fail. And so many times, whether or not we're in management, whether or not there's capital at risk, whether or not sometimes there's maybe careers at risk, if we're afraid of failure, we get paralyzed, right? And you can apply that to so many different environments, in which case not being afraid to fail means that, listen, we're going to screw things up. That's why we have a team. Let's be accountable to each other. And let's have the environment fully established, whereby when Townsend is screwing things up, my people tell me that I'm screwing things up, in which case I'll nod, smile, thank them tomorrow. Maybe not today, but I'll thank them. And then there'll be a group hug, and then we'll move on, and then we'll pivot. But the pivot is the real time feature that makes it that makes this thing work. So that's my interpretation of fail fast, fail forward. When we create that environment, it becomes then a safe space to try new things, right? And nothing stifles innovation as quickly as saying, "Oh, well, that's not the best practice." Who defines the best practice? I want to find whoever the best practice person is, and I want to see them in orange. I don't want to be the guy in orange. I want to see the best practice people in orange. But nothing kills innovation as quickly as saying, you know what, someone already figured that out. They're much smarter than you are, and so you really ought to go home and just think about that. So let's try it, even if it means we fail. And the most costly failure of my career to date was maybe an issue of maybe about $1.3 million. I didn't get fired for it. We failed miserably. I learned a lot. I was accountable for my failure. And guess what? The value that we created through that failure turned into a much more enhanced value proposition by virtue of the fact that we had learned from our mistakes. And we went on to do very, very well. That $1.3 million was a small investment compared to the eventual return.
So the failing forward is taking one step back and then trying to go 2 steps forward with that concept. Okay.
Yeah.
And how do you explain to healthcare executives, because I struggle with this regularly, who say, well, we're in healthcare, and so failure is not an option. We can't have any problems. It has to all work perfectly, and it has to work perfectly the first time. How do you deal with that kind of mindset? Which, again, I totally respect. I get it, but it's not accurate. Of course, one would assume that we're not trying to kill patients here, that a failure simply means that we're going to be spending money unnecessarily, or things that we thought were going to make some minor improvement actually didn't make an improvement at all. That's what we're talking about generally with failure. How do you kind of get that message across to executives?
Yeah, so a great place to start, as you just pointed out, is there's no death and dying involved in the failure that we're talking about. So this is not getting into patient safety and trying things out at the expense of potential harm, obviously, right? But in that, the freeing thing as you get into healthcare administration as a physician leader is yes, I've been to many codes, and I've been the physician responsible for patient outcomes for my entire career. Using that mindset creates a willingness to tolerate risk in a business environment, however, that gives us a little bit of an advantage, because I know that if I go and try something with a revenue cycle innovation, nobody's going to die, right? And there's not going to be a code. And at the end of the day, yeah, we might be a little bit further behind in our budget, and we might miss budget for the month. But again, fail fast and fail forward. We'll figure it out next month, and we're going to do better next month because we've just learned from what we did. And so applying that concept really does differentiate, I think, clinical leaders in many cases in healthcare administration. Many people have never been on the front lines of assuming risk in a patient care environment, and that's the weight that we bear as clinicians. I will tell you, leaving that behind, as I say, I retired from clinical medicine to turn into a healthcare administrator. There's nobody going to get hurt if my project doesn't end on time, and there's going to be no patient safety episodes, by virtue of the fact that a budget cycle is a little bit altered by virtue of a project that I've got underway.
I think that's really insightful what you said about kind of clinicians, people who treat patients are used to taking risks. Not like, let's see what happens, but hey, there's only 3 options and all of them are bad. Yep. And yeah. we have to deal with that. Or I can't wait until I get all of the information to make the best decision. I have to make a decision now in an emergency situation. And yeah. I'm going to make the best decision I can with the information that's available now because I can't wait. And for a lot of folks who don't deal with that on a regular basis, that's crazy. It is crazy. It's why, you don't want to make a decision till you have all the information, but oftentimes in healthcare, there's no option. You have to do that. So
yeah. As long as you're measuring your outcomes as well, right? And so one of the epiphanies in my career was the introduction to the notion of a control chart or a Shewhart chart, where time is on the horizontal axis, and you've got an upper control limit, a lower control limit, and you intervene. You make an intervention, and then you measure your outcome. So let's try something, and then let's see what happens. And then if it was a good intervention, then guess what? You get to compress your control limits, and you get to reset your ground zero or your starting point in your control chart. And then you measure going forward again. So that really factors into that fail fast and fail forward concept, where if time is on your side, let's try it. Rapid cycles of continuous improvement, right? That's what makes the world better.
Well, that is what makes the world. I was going to start singing a song about making the world go round, but that is rapid cycles of continuous improvement, small little iterations. And sometimes you're right, sometimes you're wrong, but as long as you're moving forward, you're making progress.
Yeah.
Well, Dr. Townsend, it's been a great conversation. We're getting near the end of our time. I wanted to ask you a question that we ask all the folks on our podcast, which is, are there things in your life that are so well designed that they bring you happiness and joy? And oftentimes these are not in the healthcare sphere. So is there something in your life that is so well designed you're thankful for it on a regular basis?
Absolutely. So joy in my world, I'm 6'7". Joy is defined as the absence of pain, right? So a joyful experience for me walking through a door is that I fit and I don't hit my head and there's no pain. So apply that to now fitting in the driver's seat of a vehicle. I haven't fit in a vehicle since I was 14 years of age. And then Ford had this design challenge, and I was not a Ford fan, let me just say, because my first car was a Ford Escort and I had to fold origami to get into it with the seat reclined and my head hitting the ceiling and me driving from the back seat. I would cruise through town and it would look super cool in my Ford Escort. But then you fast forward a few years, Ford apparently got the memo that people my size don't fit in a Ford. And they had a design challenge, which led to the Ford Maverick, which was to say, let's identify extreme users. Apparently I'm an extreme user. And they came up with a driver seat that I actually fit in. They installed that in Ford Broncos. And for the first time since the age of 14, I actually fit in a vehicle and I'm not in pain. So that brings me joy.
How does this work? I'm fascinated by this. What did they do to make it easy for you to fit in there? Now, again, I am almost as tall as you. It's just about 1.5 feet or so difference. So I feel your pain.
I look up to you.
Yeah. When you're sitting down, maybe. What's the magic there, or can you put your finger on it? Is it a bunch of things or one major thing?
Yeah, no, it's interesting. So if I sit in a Ford F-150, I don't fit. But if I sit in a Ford Bronco, they had this innovative concept, which was, what if we allow the front seat, allow the user to push the front seat all the way into the back seat, right? So you move your seat back, and guess what? There's no one can sit behind you anymore because you're all the way in the back seat. Instead of having to recline your seat like I did in the Ford Escort, you can now move your seat back and accommodate your leg length, even if you're 6'7". That's a novel concept, right? So take that, and then the other novel concept was, we don't need to have a super fancy driver's seat. In fact, it actually looks pretty basic, but it doesn't create this forward-leaning posture where you're hugging your steering wheel and therefore you don't hurt. And so hats off to these people at Ford. I'd love to meet the people who designed this thing, but thanks to them, I can get out of a car and I'm not in pain. That brings me joy. It's a joyful day every day I get in the car.
All right. I am now dedicated to finding that person at Ford and connecting you two and putting it on video and going viral. And as the kids tell me, if we do that, we're all going to be gazillionaires. So
that's it. Yeah. And I want a Maverick out of it. If I get a Maverick out of it, I'll be happy.
You're going to take fame, and you'll be happy with the fame. And I'll get the Maverick and or the cash equivalent, because it's my brilliant idea. Thank you again. This was great, and I'm glad that you fit in a car and that you fit in a car without pain. And I hope other aspects of your life. I'm afraid to even ask you about airplanes.
Let's not have that conversation.
We're not going to go there now. All right. Well, be well. Thank you again for kind of educating us, and look forward to that Ford reunion that I'm going to be planning in the next year or two.
Thank you so much. Thanks for having me on.
Thanks for tuning in. We hope you enjoyed today's episode. For more information about Dr. Townsend, visit bsmhealth.org. Check back for more episodes of Designing for Health wherever you listen to podcasts, or on NordicGlobal.com. Till next time, we'll see you in network. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.